Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazeru. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at magnesium sulfate in the labor ward. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. So remember that magnesium sulfate is going to be used as a first line for any pregnant woman that actually comes in and has a seizure. This is going to be including the bracket of women that have known epilepsy. And remember, whenever you're giving this magnesium sulfate, you're going to have to take additional measures, especially when you're giving intravenous fluid administration, because one of the side effects of magnesium sulfate is that they may actually be hypotensive. And this may potentially put the patient at risk of pulmonary edema with the excess IV fluids that you're giving. So magnesium sulfate can actually be used as an anticonvulsant in the prophylaxis as well as the treatment of eclampsia. And in most cases, when we say magnesium sulfate, it's a synonym for magnesium sulfate heptahydrate. So what's the mechanism of action? Remember that it's actually thought to trigger cerebral vasodilatation and reducing the ischemia that is generated by the cerebral vasospasms, especially those that are seen during an eclamptic event. So the substance itself is also a competitive inhibitor of calcium, so it's going to block the entry of calcium into the synaptic ends, and thereby it can actually alter the neuromuscular transmission. Potentially, magnesium sulfate can be used as a tocolytic. Indications of use include for women that have preeclampsia, whom are at risk of developing eclampsia, those that have severe preeclampsia, for the first-line management of an eclamptic event, as well as for the first-line management of any seizure during pregnancy, as well as neuroprotection of the preterm infants. And don't also forget that the magnesium sulfate can also be used as a tocolytic. Now, how exactly does it come? So generally on our wards, we're going to be having a 10 ml solution. But remember that you're going to be receiving 50% magnesium sulfate, or sometimes you may have 20%. Most of the formulations that we have in our setting here are going to be 20% magnesium sulfate. So the concentration is going to be 1 ml is going to give you 500 milligrams of the magnesium sulfate. So that gives us 50% weight by volume. So it means that if you have a 2 ml solution that's made up of 50%, in essence what you're going to be having there is 1,000 milligrams of magnesium sulfate, or 1 gram of magnesium sulfate. So if your vial comes as 2 mls, the solutions are 2 mls that the hospital stocks. Remember that each of those ampules, that's 2 mls consisting of 50% magnesium sulfate, is going to give you 1 gram of 50% magnesium sulfate. Then if it's the 10 ml solutions, remember that 10 mls is going to be equivalent to 5,000 milligrams, or essentially 5 grams of magnesium sulfate of 50% magnesium sulfate. Because remember, if 1 ml is giving us 500 milligrams of magnesium sulfate, 10 mls is going to give us 10 multiplied by 500 milligrams. So this vial is going to be consisting of 5 grams of 50% magnesium sulfate. These 10 ml solution vials are the ones that we routinely have on our labor ward, and those are the ones that are going to be stocked. So the calculations that I'm going to be explaining in this PowerPoint presentation are going to be based on the 10 ml solutions that we have in our labor ward. Additionally, you may have the 50 ml vials, and these ones are going to have a total of 25,000 milligrams. So in essence, they will have 25 grams of 50% magnesium sulfate. So make sure that you actually check the vial of magnesium sulfate before you actually dilute it and before you actually start to do the calculations, because how much you're going to be getting from that vial will be dependent on the percentage, whether it's 50% or 20%, as well as how much total magnesium sulfate is found in that particular vial. So remember, in our setting, we're going to be stocking the 10 ml vials that have 5 grams of magnesium sulfate. So here are the different types of vials. These are the ones that look like dextrose, but you can also get the longer vials. So there may be different stocks of the vials on your wads. So here, as you can see, here you have a 10 gram per 20 mils. Here you have a 25 grams per 50 mils. So this is a 20 mil vial. This is a 50 mil vial. Then of course this is also a 50 mil vial. So this one is going to be consisting of 25 grams of 50% magnesium sulfate. As you can see, 1 mil is equals to 500 milligrams. So in essence, that's 50% magnesium sulfate. Same thing here, 1 mil is equals to 500 milligrams. So this is 50% magnesium sulfate. So this is another 50 mil. So it means that this is going to consist of 25 grams of magnesium sulfate in total. While it's on this diagram here, the smaller vial, this one is going to be 20 mils, but it's still 50% magnesium sulfate. So all these solutions are 50% magnesium sulfate. Remember, if it was 20% magnesium sulfate, it means that 1 mil is going to give you 200 milligrams of magnesium sulfate. But in this case, we're referring to 50% because that's what is going to be stocked on most of the wards in our setting. So what's our route of administration? So it depends on the regimen that you're using. So generally there are two main types of regimens. In our setting here, we use the pre-charge regimen, and in other countries they do use the Zuspan or Sibai regimen. So remember that in the pre-charge regimen, we're going to be giving 4 grams IV over 5 to 20 minutes, and the formulation that you're giving as IV is 20% magnesium sulfate. But now you see the problem that we have. On our wards, we're going to be having 50% magnesium sulfate, but the IV formulation that a person must receive is 20%. So we're going to have to dilute it in a way. Then this at the same time is given as together with 10 grams deep IM, 5 grams in each buttock. This is the undiluted 50%. So when the patient actually has a seizure, or if you're giving it as prophylaxis, you're going to be giving a loading dose. So this loading dose is a total of 14 grams of magnesium sulfate. So the 4 grams is given as IV. It's going to be given as 20%. So that's the one that you're going to dilute if you have the 50% solution. If you have a 20% solution, you can give it just like that. But if you have the 50% solution, you have to dilute it. Then the maintenance doses are going to be given 4 hourly on each alternate buttock. These are also going to be the undiluted 50%. Then in the intravenous regimen or the Zuspan regimen, we give about 4 to 6 grams IV. Again, this is 20% over 15 to 20 minutes with a maintenance dose of 1 to 2 grams per hour IV for 24 hours. There are certain things that you're also going to be checking for before you actually administer these doses of magnesium sulfate. So how do we prepare this and how do we administer it? So remember that with the regimen that we're going to be using in our setting, it's the pre-charge regimen, where we're going to be giving initial bolus or a loading dose of 14 grams of magnesium sulfate. Now, how do you give this 14 grams of magnesium sulfate? You're going to say 4 grams, which is 20% magnesium sulfate. This is going to be given over 5 to 20 minutes IV. Then the 10 grams, the remaining 10 grams is going to be given as 5 grams IM in each buttock. So this one is going to be the 50%, which doesn't require any dilution. Then after that, you give your maintenance doses after every 4 hours in each alternating buttock with a deep IM. Then when you are preparing the medication, the first thing that you want to do is you want to wash your hands thoroughly with soap and water, or you could use an alcohol-based hand sanitizer. Then I'll start to discuss this preparation in pretty much 3 sections. So the first section here is how we're going to be able to prepare the 20%, the one that you're going to be giving IV. The second section is going to be dealing with how we're going to be giving the deep IM. Then the last section is going to be pretty much what if a patient fits, how are you going to give that extra 2 grams of the magnesium sulfate. So we'll begin with the first preparation. This is now preparing the 4 grams of magnesium sulfate. So keep in mind the background that we had is that, number one, the vials that we have on our wards are going to be consisting of 10 mils in total. of magnesium sulfate, they're going to be 50% magnesium sulfate. But remember that this 50%, we can't give it IV because it's going to be associated with a lot of complications. We can't give it directly. We have to dilute it and give 20%. So the preparation for this is pretty much going to require 20 ml syringe, 120 ml syringe. It's also going to be requiring sterile water for injection. It's also going to be requiring either sterile water for injection or normal saline or 5% dextrose. Any of the 3 solutions can be used. So remember that we're having 1 ml is equal to 500 milligrams, 50% solution. But in this case, we want to get 4 grams. So if 1 ml is equals to the 500 milligrams of the magnesium sulfate, it means that in this 10 ml syringe, the whole 10 ml syringe, we're going to be having pretty much 5 grams. So it means that from the 10 ml syringe that has 50% magnesium sulfate, it gives you 5 grams of the magnesium sulfate. But we want to get 4 grams. So 10 ml is equals to 5 grams. So 4 grams is equals to X. Then 4 multiplied by 10 divided by 5. So that gives us 8 mils. So it means the first thing that you're going to be doing is that you're going to be getting 8 mils from that 10 mil 50% magnesium sulfate. So it means you're going to be having 8 mils of this. If you multiply 8 by 500, because 1 mil is equals to 500 milligrams of magnesium sulfate 50%, this is going to give you 4 grams. So in this syringe, in this 8 mils is going to be consisting of the 4 grams of magnesium sulfate. Now remember that this is 50% and we're not going to be giving the 50% as an IV formulation. We have to dilute it. Now the formula that you use to dilute is like as follows. So you have your available concentration divided by the required concentration minus 1. So our available concentration is 50%. Our required concentration is 20%. So 50 divided by 20, it gives us 2.5 minus 1, it gives us 1.5. So it means for every 1 part of the 50% solution that we have, we must add 1.5 parts of either water for injection or normal saline or 5% dextrose. So it means if we had 8 mils of the 50%, so if we want to further dilute it to 20%, it means we're going to say 8 multiplied by 1.5, so it means we're going to be getting 12 mils of water for injection or normal saline or 5% dextrose. So it means in that same syringe, we're getting the 8 mils of 50% magnesium sulfate, then we're going to be adding 12 mils of the sterile water for injection, the normal saline, or the 5% dextrose. So it means you're going to make a solution that is going to be consisting of 20 mils. This 20 mils is going to be broken down as follows. It's going to be consisting of 8 mils of the magnesium sulfate, 50%, as well as the 12 mils of water for injection or normal saline or 5% dextrose. So in essence, what you're going to be having there is a 20 ml solution of 20% magnesium sulfate, which consists of 4 grams of magnesium sulfate. So in essence, you have 4 grams of magnesium sulfate, which is 20%. Then once you have this 4 grams of magnesium sulfate, which is 20%, then you're going to be giving this IV slowly over 5 to 20 minutes. If you are still confused about this, pause the video, read through the text. You're able to follow each and every single step. So that's how we prepare the 20 ml solution, the 20% solution. Then remember that when you're administering the loading dose, you want to check your BPs. You want to do 5-minute BPs and pulse readings, so you should take about 4 readings. You want to observe for any development of the side effects, which I will mention at the end of this lecture. You also want to check the patellar reflex after administration. You want to record A if it's absent, N if it's normal, B for brisk. Then how do we prepare the one that we're giving IM? This one is very easy because it doesn't need to be diluted. So remember, from our vials, we have 1 ml is equals to 500 milligrams of magnesium sulfate. If we have a 10 ml bottle, it means that we're going to be having 5 grams of magnesium sulfate. So all we just simply do is to draw 10 mils of the 50% magnesium sulfate. Then we have the 5 grams. Then in this 5 grams. Remember, magnesium sulfate is also quite painful when it's being injected. We want to add 1 ml of 2% lignocaine to each of the syringes. So what you need is you're going to be getting 20 ml syringes. We draw 10 mils of 50% magnesium sulfate. That's going to equate to 5 grams of magnesium sulfate. Then in each of these mils, you're going to be adding 1 ml of 2% lignocaine. So you inject the first syringe by deep IM into the left buttock. Then you inject the second syringe by deep IM into the right buttock. Then remember, these are going to be your maintenance doses after every 4 hours. So you're going to be giving them after every 4 hours after checking for certain parameters that I will talk about very shortly. Then what if a patient actually seizes? It means that if a patient actually had received the loading dose and after 5 minutes they seize, you want to add an extra 2 grams IV. Now remember, this extra 2 grams IV that you're giving is also 20%. Now remember, our vials are going to be coming 10 mils is equals to 5 grams of 50% magnesium sulfate, but we want 2 grams of 50% magnesium sulfate. So 10 mils is equals to 5 grams, so X is going to be equals to 2.5. So 2.5 multiplied by 10 divided by 5. So it means that from this preparation, from the 10 mil vial, we want to get 4 mils. That's if you have a 10 mil vial. We want to get 4 mils. So we'll get the 4 mils of 50% magnesium sulfate, but remember our conversion factor and our dilution factor. For every 1 part of magnesium sulfate, 50%, we must add 1.5 times of the water for injection or the normal saline or the 5% dextrose. So if we multiply 4 mils multiplied by 1.5, it gives us 6 mils. So it means that you're going to be having a 10 ml solution consisting of 4 mils of 50% magnesium sulfate and 6 mils of water for injection or normal saline or 5% dextrose. So you're going to be giving this 10 mils slowly over 5 minutes. Then after you've given the magnesium sulfate, you actually can decontaminate the needles by flushing the needle in the syringe with 0.5% chloride. Do this 3 times, then you place it in a puncture-proof container. We remove the gloves, we discard them in a leak-proof container or plastic bag. Then we should wash thoroughly with the soap and the hands, or use our alcohol-based hand sanitizer. So that's generally how we're going to be giving the magnesium sulfate. Remember, we're giving our loading dose 14 grams. 4 grams is given as IV, 20%. Then the 10 grams is given as a deep IM, that's the 50%. In the left buttock and in the right buttock. Then we repeat with the maintenance doses every 4 hours, but there are certain parameters that we check for. So for the monitoring of signs of toxicity, you generally want to count the respiratory rate for a full minute. Every hour, the rate should be equal or greater to 16 breaths per minute. Then we should also do our patellar reflexes. We do this every hour, so we place one hand under the woman's knee, then we lift the leg off the bed, we tap the patellar tendon that's just below the kneecap with a patellar hammer or a reflex hammer. We should note some contractions in the muscles of the thigh. Then we should insert an indwelling urinary catheter and measure the urinary output, and the output should be at least 30 mils per hour. And before we actually repeat the maintenance doses, we should check that the patient at least has a respiratory rate greater than 16 breaths per minute. The patellar reflexes must be present, and the urine output must at least be over 30 mils per hour for the past 4 hours. Then if it is, then we give our 5%, the 5 grams rather of magnesium sulfate, 50% solution, together with 1 ml of the 2% lignocaine. So it means you're going to be giving a total of 11 mils. So we're going to be giving 10 mils of the 50% solution. You're also going to be giving in the same syringe 1 ml of 2% lignocaine. You mix them in the same syringe. Then of course this should be alternating every 4 hours. So this is going to be given until 24 hours after delivery or 24 hours after the last fit, whichever is the last event to actually occur in this patient. Then you want to withdraw the drug if you notice that the respiratory rate has fallen below 16 breaths per minute, if the patellar reflexes are absent, if the urine output has fallen below 30 mils per hour over the preceding 4 hours. So in cases where you actually administer the drug and you notice that there's respiratory arrest, you want to call for help. You want to assist ventilation with bagging and masking. You want to give an antidote. In this case, it's calcium gluconate. You want to give 1 gram. So you're going to be taking 10 mils of the 10% solution, and it's available as 2.2 millimoles of calcium. That's going to be found in a 10 ml vial. You want to give this slowly over 10 minutes. This patient requires ECG monitoring during and after the administration of this calcium gluconate because there is a potential for cardiac arrhythmias. Then there are some instances where we want to monitor the levels of magnesium sulfate in the bloodstream, but this is not routinely done. So remember that our therapeutic levels are going to be between 1.7 to 3.5 millimoles per liter, and keep in mind that magnesium sulfate is going to be excreted by the kidneys. So the monitoring the levels of the serum should be done, especially in patients with renal impairment. So 6 hourly or more frequent if it's indicated. So you want to actually review the levels of magnesium sulfate and actually involve your consultant or your senior. If you notice the respiratory rate is less than 12 breaths per minute, the urine output is less than 100 mils in the 4 hours, then there's loss of the patellar reflexes, or if further seizures keep occurring. Then if the serum levels is greater than 3.5, we generally want to stop the magnesium sulfate. So here are different levels and different concentrations and their effects. So between 0.8 to 1.0, normal plasma levels. Between 1.7 to 3.5, that's the therapeutic range. Between 2.5 to 5, that's where you even sometimes get the ECG changes. The PQ interval prolongation, widening of the QRS complex. 4 to 5, there's a reduction in the deep tendon reflexes. Greater than 5, there's loss of the deep tendon reflexes. Greater than 7.5, there's sinoatrial and even atrioventricular blockade. There's respiratory paralysis and CNS depression. Greater than 12, you have cardiac arrest. So greater than 3.5, generally you want to avoid the magnesium sulfate. Some side effects include hypotension. That's going to be secondary to a reduction in the systemic vascular resistance, because remember, this is some sort of a vasodilator. Then you also want to give the fluids with caution when you're combating the hypotension, because there's an increased risk of pulmonary edema. You may also have facial flushing, visual disturbances, flushing at injection sites, chest pains, nausea. You may have nasal stiffness rather. You may have ECG changes. You may have gastrointestinal abscess. You may have urinary retention. These are all features of magnesium. You may also have features of magnesium toxicity. Then there may be some tissue necrosis, especially at the injection site. So make sure you examine the injection sites. So in terms of contraindications and precautions, remember that magnesium sulfate must be administered with caution in women that are being treated with cardiac glycosides like digitalis. Then you may also have those that are concurrently taking the CNS depressants, because there is an additive effect of magnesium sulfate with the other CNS depressant that can actually even further depress the CNS if it's given together with magnesium sulfate. Then remember that calcium gluconate, which is required to treat the magnesium sulfate toxicity, should also be given with caution because it may precipitate heart block, which is why there is need for an ECG. Then remember that magnesium sulfate is going to be excreted in the urine, and patients with impaired renal function or electrolyte imbalances, you must actually cautiously manage them and check the levels of magnesium sulfate very closely, because there's an increase in risk of magnesium toxicity. I really hope you enjoyed this video on magnesium sulfate, use in the labor ward. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.